All right, good morning, guys. Welcome back to the second day of the Texas State of Enrollment Conference. Our conference is co-hosted by the Texas Association of Community Health Centers, Young Invincibles, and Every Texan. I'm Stacy Pogue, a policy analyst with Every Texan. We are very grateful to Methodist Healthcare Ministries for their sponsorship of our conference. Today, the full day, we'll have a morning session and an afternoon session, all of it dedicated to the PHE, stands for Public Health Emergency. I know you heard that acronym, I'm going to say a dozen times yesterday, and we kept saying, hold on, we'll go more in depth tomorrow. So today, you're going to hear PHE many more times. And by the end of the day, if it's a new concept to you, I promise you, you'll feel very comfortable with what's coming up at the end of the public health emergency. And starting with this session, I'm going to go over real quick some housekeeping pieces about the webinar today, and then I'll introduce our speakers. So if you guys want to enable closed captions, you can do so. On the slide, it shows how you can click on the bottom of your Zoom screen. There's a button that says live transcript. Get that one right. To enable closed captions. Hold on a second. I'm just making sure I got the instructions on closed captions right. Sorry about that. All right, you can talk, sorry, after you click on that, you need to toggle closed captions on. All right, sorry, next slide. And here's some other requests from us. I'll give an overview of the speakers as I introduce them, but I won't give their full bio, so you can go to our website and see all of the bios of all of our speakers for the whole conference. We do have a request because we have so many attendees in the webinar that if you have a question, click on the Q&A button on the Zoom, the Q&A icon on your control panel, and then you'll be able to type your question into the box. You can go ahead and type your question as they come up, and then we will hold them and ask them to the presenters. At the end of the session, we'll have time for Q&A. And at that time too, we'll be able to, if you're having trouble typing your question for some reason, you can raise your hand at the end and we can unmute folks if there's time, but we'll go first through the questions that are typed into the Q&A. Please don't type your questions in the chat. I am super excited to see how many people are already using the chat to introduce themselves and say hi. So the chat's a great place to interact with other participants, but it makes it easier for us to find the questions for our presenters in the Q&A. And the first question you guys are all going to ask, so I'm going to answer it now, is that yes, these webinars are being recorded. Yes, the slides will be available afterwards, so you don't have to try to scribble everything down. By Monday on our conference website, we will have all the slides available, and we'll have the recordings of the sessions available so that you can share them with any of your colleagues, or you can print out the slides if you'd like. And at the end, we'll have a quick evaluation of the session today, and then we'll do a raffle to raffle off a $50 Visa gift card. So hang in till the end, please. All right, I think I got all the Q&A. And so what I want to do is introduce quickly our speakers. Oh, thanks. Okay, this morning we're going to have Understanding the PHE, What's at Stake. The conference planners have affectionately been calling this session PHE 201 to build the foundation of knowledge. And this afternoon we're calling that affectionately PHE 201, where we're going to do some more skill building and best practices with some expert enrollment assisters who are going to help lead that. But back to this morning, we have two experts that if there was such a thing as a PhD in the PHE, these two ladies would already hold that designation. First, you're going to hear from Tricia Brooks. She's a research professor at the Center for Children and Families, which is part of the Health Policy Institute at the McCourt School of Public Policy at Georgetown. That's an independent nonprofit policy and research center that works to expand and improve health coverage for children in low-income families. And she's a national expert on Medicaid eligibility, Medicaid and CHIP eligibility. Then you'll hear from Gina Carter with HHSC. Gina is a senior policy advisor to the HHSC Deputy Commissioner for Access and Eligibility Services. She's worked with HHSC for more than 30 years. And as a proud member of the Gina Carter fan club, I'm going to put aside her amazing bio and formal bio and just tell you that there is a policy manual for Medicaid, CHIP, SNAP, TANF, I missed one or two programs at HHSC that's as big as the Houston phone book, and Gina knows it forwards and backwards. But that is not her only superpower. She can then translate that deep encyclopedic knowledge so that people can use it, whether the computer programmers that program the eligibility system or advocates and enrollment assisters. She always makes the information usable and understandable to wide audiences. So, oh, and also she's on the team of dedicated public servants who have been preparing at HHSC for the monumental task of unwinding the PHE for not just months now, but years. And so I'm grateful for all of their work, and also that Gina and some of her team were able to join us today. Okay, that's my introduction. I'm going to hand it over to Tricia, who's going to present first. Then we'll have Gina, and we'll take questions after both of them present. And I think we're going to get your slides up in just a second.
Okay, well, thank you, Stacy, and good morning, everyone. I really appreciate the opportunity to talk with you today about the unwinding of the Medicaid continuous coverage protection. No doubt, this will be the largest single event ever impacting enrollment in Medicaid and CHIP, particularly for children in Texas. It is unprecedented because the coverage protection will have been in place for at least 3 years, and the effort to renew for everyone comes at a time when state capacity has been impacted by challenges in retaining and recruiting an adequate state eligibility workforce. Next slide, please. So let's start with some basic background for those who may be new to the Medicaid space. In March 2020, when the COVID public health emergency was first declared, Congress stepped in quickly, as it commonly does during economic downturns, to provide fiscal relief to the states to help offset the counter-cyclical effects of increasing Medicaid enrollment and falling state revenues. Since the first quarter of 2020, states have received an additional 6.2 percentage points in the federal share of funding for Medicaid and 4.34 percentage points for CHIP. Generally, there are strings attached to federal fiscal relief in the form of maintenance of effort provisions, or MOEs, that require states to maintain eligibility levels and prevent states from implementing new administrative barriers to coverage, such as increasing premiums. But it was the combination of the public health emergency precipitated by COVID and its economic fallout that prompted Congress for the very first time to add a third MOE provision to protect Medicaid enrollees from loss of coverage during the pandemic. Recently, the Kaiser Family Foundation published an analysis of state-level fiscal relief compared to state spending on additional MOE enrollees. The analysis shows that through September of 2022, Texas was projected to receive nearly $8 billion in additional federal funding, of which less than half, $3.4 billion, was spent covering MOE enrollees. In essence, the bump in federal for Medicaid has done what was intended, providing Texas with over $4.5 billion in surplus federal fiscal relief, while protecting the primary source of health insurance for children, pregnant women, people of color, and rural communities. Despite this surplus, there will be fiscal pressure on states to move quickly, since the bump in federal funding only extends until the end of the quarter after the MOE is lifted. Next slide, please. As a result of the MOE, as well as shifts in employer-based coverage, Texas Medicaid and CHIP enrollment increased from 4.2 million to over 5.5 million between February 2020 and June 2022. Over 4 million children and nearly 1.5 million adults in Texas are covered by Medicaid and CHIP. Next slide, please. Now, these data reflect the fact that in Texas, children represent a much higher share of people covered by Medicaid and CHIP, 73% compared to 46% nationally, largely because the state has not expanded Medicaid to adults, and the parent eligibility level in Texas is the lowest in the country. As a result, children are much more likely to be enrolled. Next slide, please. Now, these data compare the percentage change in Medicaid and CHIP enrollment in Texas to the US since the month before the continuous coverage protection was enacted. As you can see, enrollment in Texas has increased by 23.7% compared to 26.5% nationwide. Child enrollment has grown by 27.8% in Texas compared to 16% nationally. And for adults, Texas enrollment's grown over 40% compared to the national growth of 36%. Next slide, please. Now, I'd like to turn our attention to data that may be helpful in assessing the state's readiness to begin unwinding the continuous coverage protection. This slide's a bit busy, but I want to use it to illustrate 2 points. The data are based on CMS analysis of state-reported timeliness in processing new applications. However, the CMS annual report covers only a 3-month snapshot each year. But you can see here in February and March of this year, there was an increase in the share of applications that took longer than the 45-day standard to process. I'll come back to this point in the slide, but the other comment I wanted to make on these data is in the circled column. This is the detailed data published by CMS for Texas, reported as the share of applications processed in various timeframes. The share of applications processed in less than 24 hours, circled here, is reflective of a state's success or lack thereof in approving applications using available electronic data. Income and other data sources available to the state are used to process eligibility for both applications and renewals. And in national surveys published by the Kaiser Family Foundation, Texas reports that less than 25% of enrollees are renewed using data available to the state, a process known as ex parte. Higher shares of data-driven eligibility determinations and ex parte renewals reduce state administrative burden while promoting enrollment and retention and avoiding procedural disenrollments. Next slide, please. And back to timely processing. This slide reflects Texas data, which is more recent and monthly. And as you can see, Texas has continued to struggle with application timeliness over the past 6 months. Medicaid redetermination timeliness has also declined. And the low share of data-driven eligibility determinations at application and renewal, coupled with decreasing timeliness, does not bode well for the state's capacity to stay on top of the workload once the unwinding begins at the end of the PHE. Next slide, please. So, how will the PHE end and when will it end? As expected, just last week, Secretary Becerra extended the public health emergency until January 11th, 2023. The Biden administration has promised to give states 60 days advance notice before the end of the PHE, which would be November 12th of this year. But that's a Saturday in the middle of Veterans Day holiday weekend, so we're probably safer waiting until Monday, November 14th to know for certain if the administration plans to let the PHE expire in January. However, there could be other action. Congress could act to delink the continuous coverage protection from the PHE on a date certain. And additionally, states are not obligated to continue to accept the bump in federal funding. Any state could reject the federal dollars and no longer be subject to the MOE. Next slide, please. I'm not going into detail on this graphic, but it shows the timeline under the scenario that the PHE will end in January. It indicates when states may initiate renewals, how long they have to complete renewals, and when the first disenrollments could take place, as well as key dates for submitting the state's summary renewal plan to CMS and beginning to report supplemental unwinding data. I'll be happy to answer questions about this in the Q&A. Next slide, please. So I think we can all agree there's a lot at stake when the PHE ends. Medicaid and CHIP are now the predominant source of health insurance for children, covering almost half of Texas children. And Medicaid is the primary source of coverage for low-income families, rural residents, and communities of color. Health coverage protects families from medical debt, which is the leading cause of bankruptcy. Medicaid also provides important sustaining revenue for rural hospitals, community health centers, and other safety net providers. In focus groups conducted in February, enrollees were clear that Medicaid has provided necessary and life-changing care. Prior to having Medicaid, most were uninsured or put off care due to cost. With Medicaid, they were able to schedule delayed surgeries, afford their medications, deal with chronic conditions, get preventive care, and importantly, access mental health services at a time when the need is increasing among all ages, but particularly among adolescents. Next slide, please. So how many people are at risk for a loss of or a gap in coverage when the continuous coverage protection is lifted? There have been several estimates of disenrollment based on different assumptions, but generally researchers predict that about 15 million enrollees nationwide, including some 6 million children, will be disenrolled during the unwinding. In August, ASPE, the Office of the Assistant Secretary for Planning and Evaluation, released fairly shocking projections that nearly half of enrollees, 45%, will be disenrolled despite remaining eligible. That's 6.8 million people. And the risk is greatest for children, where a whopping 72% of the 5.3 million children projected to lose coverage will still be eligible for Medicaid or CHIP. And people of color are also at higher risk, with an estimated 64% of Latinos and 40% of Black non-Latinos losing coverage for personal reasons. And I apologize if you hear my dog in the background because somebody's ringing my doorbell, but I am not going to step away to answer the door. But let me go back to this slide, and that is that 64% of Latinos and 40% of Black non-Latinos will lose coverage for procedural reasons compared to 17% of white non-Latinos. Next slide, please. I hope that's not too annoying. It's more annoying to me. So researchers, and I think everyone acknowledges that disenrollment will largely depend on how each state handles the unprecedented volume of eligibility determinations after the PHE ends. Texas will need to conduct full renewals on over 5.5 million Medicaid enrollees, including nearly half of Texas children. There is reason to believe that disenrollment could be even higher than the ASPE data I shared, largely due to the unique circumstances of the unwinding. Under a higher than typical scenario of churn, ASPE projects that as many as 10.2 million enrollees may be disenrolled despite still being eligible. Unfortunately, researchers have not projected coverage losses on a state level basis. Next slide, please. Even in the best of times, churn in Medicaid is a problem. According to a recent churn analysis published by MACPAC, over 1/3 of all enrollees and 43% of children who were disenrolled and did not transition to other public coverage in 2018 re-enrolled within 12 months. Importantly, the analysis indicated that state policies and procedures impact churn. States that have 12-month continuous eligibility for all children, that do not conduct periodic data checks between renewals, or that higher rates of automated renewals using data available to the state, all have lower rates of churn. And similar to the ASPE projections, the MACPAC study also found that the churn rate was higher for Black, Latino, and Indigenous enrollees. Next slide, please. Now, it was long before reading the ASPE report that the risk of the share of eligible enrollees losing coverage for non-eligibility reasons had been keeping me up at night, along with the difficulty of transitioning to other coverage. Some view procedural denials and disenrollments as a failure of enrollees to provide information, but there are many reasons that people don't respond to requests for information, from never receiving the mail, to not understanding the notice, to not being able to get questions answered. Some enrollees, particularly those with multiple part-time jobs, fluctuating hours, and gig workers, may have difficulty in providing income documentation. And states can lose paperwork. In reality, it's a failure within the system to streamline the process and remove administrative hurdles to enrollment and retention. And when someone is no longer eligible, there are barriers to transitioning to other coverage, including affordability, limited special enrollment periods, and complex application and plan selection processes. Even children can experience delays in moving between Medicaid and CHIP, which I'll talk more about in a moment. Next slide, please. So what coverage options will people who are no longer eligible have? Both ASPE and the Urban Institute predict that the majority of children no longer eligible for Medicaid will still be eligible for CHIP. Nationally, less than 10% of children will be eligible for marketplace financial assistance, compared to about 1/3 of adults, now that the premium tax credits have been, the enhanced ones have been extended. This means that eligibility for most children will differ from their parents. And in non-expansion states, there will be many parents losing Medicaid who have no affordable coverage options. Next slide, please. And how smooth will these transitions to the marketplace be? The MACPAC analysis showed that less than 4% of Medicaid disenrollees enrolled in the federal marketplace in 2018, with over 70% of those experiencing a gap in coverage. Although Medicaid and CHIP should be seamless for children, the data showed that 1 in every 5 children experience a gap when moving between the two programs. Next slide, please. But despite all this uncertainty, what is clear is that millions of low-income children and families don't have to lose coverage if we all work together to get it right. Next slide, please. So what does getting it right look like? By understanding the state's plan and being able to monitor key performance metrics, stakeholders are in a better position to support or supplement the state's efforts. Transparency promotes both accountability and trust. Collaborating with Medicaid stakeholders will improve the state's plan and engage partners who can amplify key messages and assist individuals with renewal or transitions. It's important to balance the timeline for resuming routine operations with the workload and workforce capacity. The unwinding will be easier to manage if states take the full 12 months, and doing so will help avoid an uneven distribution of work in the future. There must be adequate staff capacity to do the work and assist families, but like other employers, states are finding it difficult to retain and recruit employees. And a large portion of eligibility workers have no experience with renewal. States risk burning out staff if they are swamped with work, which will only exacerbate staffing shortages. A robust communications plan to keep enrollees and all stakeholders informed is critical before and during the unwinding, including ensuring that notices are easy to understand. Renewals should be processed in a timely manner, but this is only possible if eligibility workers can stay on top of the workload. When workers are overwhelmed, mistakes are bound to happen and paperwork may get lost, which simply creates more work. Sending reminders, following up with enrollees via different communication modes, including text and phone, and allowing additional time to provide information or documents will improve the renewal response rate. Call centers function well when call wait times are reasonable and staff are adequately trained to provide prompt, accurate consumer assistance that enrollees will need. And keeping the share of procedural disenrollments low is critical to avoiding coverage losses. Remember, ASPE projects that 3 out of every 4 children who are disenrolled will remain eligible. Doing it right means that children and families who are no longer eligible get help transitioning to other coverage. And key monitoring data should be posted publicly, but intel from frontline organizations will supplement unwinding data to more quickly identify problems that need attention. Getting it right also means that states are prepared to pause and refine the plan if things are not going well. Next slide, please. So I want to turn a little more to some of the aspects of state planning that we've seen across the states. Getting it right involves developing a comprehensive state plan that embraces collaboration, robust communications, policies and procedures to promote retention, consumer assistance, and monitoring and rapid response. Next slide, please. Ideally, states will engage a broad array of stakeholders in all phases of the unwinding from planning to implementation to monitoring. Health plans and providers, Medicaid advisory committees, and navigators and assisters are key partners, but other entities, including legal services, policy advocates, and community-based organizations, as well as other assistance programs and enrollees, should also be involved. By prioritizing collaboration, states will enlist cadre of partners to help avoid coverage losses. Next slide, please. Before the unwinding begins, notices should be reviewed and field tested to ensure they are written in plain language and clearly emphasize what an enrollee must do to retain coverage. Providing notices in the enrollee's preferred language or with clear instructions on how to access translation services is also important. And sharing disenrollment notices with frontline organizations will help them understand why coverage was terminated so they can assist disenrollees with appropriate next steps. Beyond improving notices, a majority of states plan to conduct multifaceted, multi-phased communications campaigns, starting with updating your address or contact information. Enrollees without online accounts should be encouraged to create them. And states have deployed simple tools such as an online form or dedicated phone line to expedite the process for self-reporting. Once the PHE end date is in sight, enrollees should be alerted to upcoming changes and then encouraged to check their mail and return the renewal. A number of states are creating communications materials or toolkits for stakeholders to promote key messages. And throughout the planning, implementation, and monitoring processes, states should keep stakeholders informed. Next slide, please. Now, I could spend my entire time talking about the various policies, procedures, and flexibilities available to states to promote enrollment and retention. So this slide is not an exhaustive list. Alignment of policies between renewals and changes in circumstances and between MAGI and non-MAGI groups can streamline systems, create efficiencies, and simplify the process for both state workers and enrollees. During the unwinding, states have flexibility to align Medicaid renewals with SNAP reviews and to use SNAP income data to renew Medicaid. States also have the option of becoming an FFM determination state, which will offload the duplicative administrative effort of re-verifying eligibility. On the procedure side, taking the full 12 months is key to managing the workload and smoothing out future workloads. Other best practices include improving renewal and response rates and reducing procedural disenrollments, including maximizing the share of ex parte or automated renewals, providing extra time for enrollees to return forms, sending those reminders via different communication modes, eliminating periodic data reviews that drive churn among families with fluctuating income. And that's an issue, by the way, that disproportionately impacts low-wage earners. Eliminating or at least suspending system auto closures that can get ahead of the capacity of eligibility workers to process renewal forms and documentation is also needed. Next slide, please. There is no doubt the need for consumer assistance will be higher than ever before. Additional funding to navigators, certified application counselors, and community-based organizations for outreach and assistance is needed to ensure adequate capacity. States should keep the stakeholder community informed of state actions and system changes and provide an expedited channel for assisters to get help on difficult cases. States might also take a page from Kentucky's playbook and add features to assister portals that will offload state administrative burden and support retention. Managed care plans have a key role to play in helping keep updated contact information and assist them with renewals if the states adopt temporary flexibilities outlined in CMS guides. To support transitions, it's important to maintain a current list of navigators and assisters for use by providers, pharmacies, and other frontline organizations in referring people who need help. As noted previously, children face barriers and gaps in transitioning from Medicaid to CHIP, often due to a requirement for advance payment of premiums or enrollment fees. Eliminating the CHIP annual enrollment fee or waiving it for the first year will ease the transition to CHIP. And at the national level, efforts are underway to improve the account transfer process between states and healthcare.gov to directly connect potential applicants with assistance. To this end, it's helpful for states to double down on collecting email addresses and cell numbers and ensure that account transfers include all of that contact information. But ultimately, to maximize health insurance for Texans, the state should accept the generous federal funding available to expand Medicaid and shore up the healthcare safety net. Next slide, please. There are several steps states can take to facilitate monitoring the impact of the unwinding, starting with publicly posting key unwinding data, which I'll discuss in a moment. It's also important for the state to work with frontline organizations to identify and address recurring problems, bottlenecks, and system glitches that are inevitable when there are major policy shifts in Medicaid. Social media can be an effective way to solicit and monitor feedback, but states the value of protecting health coverage for eligible individuals and providing excellent consumer assistance should also create easy ways for applicants and enrollees to provide feedback or leave comments. At the end of the day, if a state moves too quickly and the workload overwhelms eligibility and call center workers, and too many enrollees are unable to access assistance or are losing coverage for procedural reasons, the state should be prepared to minimally slow down or potentially hit the pause button for mid-course corrections. Next slide, please. So let's turn to the data that can be helpful in monitoring the unwinding. A few key performance metrics can help us assess the impact. The canary in the coal mine will be call center statistics. As call volume increases, so do call wait times and the abandonment rate. This means that individuals' questions are not able to get help. The share of procedural dis-enrollments is another indicator that eligible individuals may be losing coverage inappropriately. Performance indicator data that states submit to CMS and the supplemental unwinding data that states are required to report monthly include enrollment, application, renewal, and fair hearings data. While we expect that enrollment will shrink if too many children and parents are losing coverage, it likely means that many will become uninsured. Additionally, trending out the number of pending applications, renewals, and fair hearings will help assess if the backlog of work is growing. Unfortunately, the data reporting lag means that a lot of people will lose coverage before the data even reflect the impact. Next slide. Because of the data lag, gathering and analyzing intel from the field is critically important in identifying issues early on. Navigators and certified application counselors, particularly those in FQHCs, who understand the eligibility and enrollment process, can help states quickly identify recurring problems, bottlenecks, and system glitches that need attention. I would encourage Medicaid advocates and stakeholders to work together to create a mechanism to facilitate the flow of intel from the field. Feedback comes in a variety of forms: the collection of formal data, surveys, informal and anecdotal, and through personal experience. Frontline organizations may benefit from assigning a point person to make sense of feedback from patients or consumers. And then having a statewide entity, for example, the Primary Care Association or the Hospital Association, might help to make sense of the impact that frontline organizations are experiencing in their sector. Next slide, please. And once the intel is gathered, frontline groups and navigators, assisters, policy experts, legal aid attorneys should compare notes to identify common themes and problems. But that effort requires coordination and may require additional resources for project coordination. I would encourage foundations to consider if there's a role for them to play in supporting a monitoring feedback loop. This should be a collaborative effort where the state and stakeholders work together to ensure that eligible kids and families don't lose coverage. And the state agency isn't the only audience for information gleaned from monitoring the impact of the unwinding. State leaders, the Medicaid Advisory Committee, key legislators or legislative committees, and the media should be informed of how the unwinding is impacting real people and their access to health care, starting with understanding why the unwinding is such a big deal and threat to coverage in Texas. Ultimately, what happens during the unwinding is up to governors and state leaders who largely control how the state Medicaid agency responds. CMS has provided an abundance of guidance and technical assistance and has stretched to identify flexibilities that can ease state administrative burden and promote retention when the coverage, continuous coverage protection is lifted. No child should be without access to the health care they need to thrive in school and beyond. And no disabled person or parent who is eligible should lose access to the health care they need to stay healthy. We need all hands on deck, using all available tools and adopting best and policy practices to promote the health and well-being of Texans when the PHE ends. And I think that is the end of my slide deck, and I look forward to hearing more from this, specifically on what the state is planning to do.
Wonderful. Thank you, Tricia, for all of that background. It was super informative. We're going to turn it over now to Gina Carter, who will tell us more about what Texas's specific plans are and what resources HHSC has created related to the PHE unwinding. Thanks, Gina.
Good morning. Yes, I'm here to provide an overview of HHSC's plans to unwind the continuous Medicaid coverage requirement related to COVID-19 federal public health emergency. Excuse me, next slide. Thank you. Today, I'm going to provide information about the reason why we are maintaining Medicaid during the COVID-19 public health emergency, how the continuous Medicaid coverage requirement has impacted the Texas Medicaid caseload, federal requirements and guidance related to ending continuous Medicaid coverage, our plans for ending continuous Medicaid coverage, including important timelines, our plans for communicating about the end of the PHE and continuous Medicaid coverage with Medicaid members, providers, health plans, and advocates, and next steps and activities we're going to continue doing until the end of the continuous Medicaid coverage unwinding period. Next slide. Thank you. As a requirement of the Families First Coronavirus Response Act, HHSC must maintain Medicaid coverage for most people enrolled in Medicaid as of or after March 18th, 2020, through the end of the month in which the PHE ends, in order to receive the 6.2% increase in the federal medical assistance percentage or federal match. With few exceptions as allowed by CMS, we have maintained Medicaid coverage for all Medicaid recipients since March 18th of 2020. As you can see from the slide, the requirement to maintain Medicaid coverage has had a significant impact on HHSC's Medicaid caseload. From March 2020 through September of 2022, the Medicaid caseload has shown a 44% increase. In March 2020, 3.7 million individuals were enrolled, and 5.6 individuals were enrolled in September of 2020. Federal guidance regarding FFCRA's continuous coverage requirements has evolved over the pandemic. The federal guidance that most impacts our plans for unwinding continuous coverage is shown on this slide. States may begin their unwind plan up to 60 days before the first disenrollments are effective. Disenrollments cannot be effective before the first of the month after the PHE ends. If the PHE were to end in January of 2023, disenrollments cannot be effective before February 1st, and states could begin their unwind process as soon as December 1st. States must conduct a full redetermination as required by federal regulations and allow members at least 30 days to respond to renewal packets or requests for information. With that background, I want to touch briefly on where we are now. We are still uncertain about the end of the PHE. The current declaration ends January 11th of 2023, and the federal government has committed to giving states at least 60 days notice before ending the PHE. According to our most recent data, we estimate as many as 2.7 million Texans have sustained Medicaid coverage due to the continuous coverage requirement and will need to have their Medicaid eligibility redetermined when continuous coverage ends. We will also continue renewals and redeterminations for the rest of the Medicaid population following normal timelines and policy. This 2.7 million member number fluctuates as we are able to renew members and remove them from the redetermination population, as well as new members who need to have their coverage renewed. To comply with the federal guidance for completing redeterminations and to manage capacity for eligibility operations, HHSC plans to take a population-based phased approach to end continuous Medicaid coverage. This staggered approach provides 4 benefits. It lessens confusion and abrasion for members who are most likely to maintain coverage, including older adults and people with disabilities. It concentrates state resources to prioritize redeterminations for those most likely to be ineligible. It reduces the risk of overwhelming the eligibility system by phasing eligibility work over several months. And it allows HHSC to resume normal operations in future years by staggering renewals dates to avoid an unusually high number of renewals for certain months. This approach prioritizes redeterminations for individuals whose Medicaid has been maintained due to the continuous coverage requirement by distributing the population into 3 groups. The first group includes individuals most likely to be ineligible for all HHSC healthcare benefits or who are ineligible for full coverage Medicaid, but are eligible to be transitioned to another program. For example, someone most likely to be ineligible for another group is a child who's aged out of children's Medicaid or an adult recipient who's no longer living with and caring for a relative dependent child. Examples of individuals likely to be transitioned to another program include children who are no longer eligible for Medicaid, but are eligible for CHIP, or women whose pregnancies have ended and are now eligible for the Healthy Texas Women's Program. The second group includes individuals who are eligible to transition to a different Medicaid eligibility group, such as children moving from the 1 to 5 group to the 6 to 18th group. People will need additional information to determine their eligibility, and other MAGI population groups whose eligibility will be redetermined through an automated alert process. This includes women who are aging out of children's Medicaid and Medicaid for former foster care children, and also those individuals who are no longer eligible for transitional Medicaid. The final group includes everyone remaining from the previous groups, including those most likely to remain eligible when continuous coverage ends, including older adults and people with disabilities. Based on April 2022 data, we estimate the first cohort to be the largest at 1.4 million members. This is because we will take all members of the household at one time. So this may include members who are likely to transition to another group and members from other households who are likely to remain eligible. We'll do the renewals at the same time. This slide provides a high-level timeline with key dates in our unwinding plan. This timeline assumes the PHE ends January of 2023. The dates will change as we extend continuous coverage, but the steps remain the same. Once we know continuous coverage is ending, we will send members a special notice that continuous coverage is ending, and they may need to take steps to respond to HHSC when they receive a renewal packet or request for information. After members are placed into one of the 3 groups, our unwinding plan will begin when we start the redetermination process on the first cohort. This starts when we run available electronic data sources to try and determine eligibility without requiring additional information from the members. This will begin in January, the month the PHE ends. Based on current law, the enhanced FMAP authorized by the FFCRA would end with the calendar quarter in which the PHE ends, which is March 31st of 2023, if the PHE ends in January. We estimate our unwind plan will take a full 8 months to complete all 3 cohorts, which would have us completing pending eligibility actions by September 1 of 2023. This is our best projection based on estimated workload and workforce capacity, but is subject to change as we work through the redetermination population. We have built into our system so that members who return their packets or additional information timely will not lose coverage while we work through their redetermination. We will continue to prepare for the end of the PHE coverage. We are very engaged with the community partners, communicating with our key partners, excuse me. Members may be confused about what information they need to submit to continue their Medicaid coverage and when they should submit it. Members have not had to take action for over 2 years to maintain their coverage. Some members may not receive their renewal packets because they have moved and haven't provided their current address to HHSC. We've created an ambassador program as part of a 3-phase communication plan. This program allows us to support external partners, providers, physicians, health plans, and advocates to help members prepare for the end of continuous coverage. The ambassador program focuses on outreach and education to members about actions members can take now, like creating a Your Texas Benefits account and downloading the mobile app, reporting changes in contact information to ensure HHSC notices reach members timely, returning renewal packets or requests for information as soon as possible after they've been received by the member. The Ambassador Toolkit, which includes FAQs, sample graphics, and talking points in English and Spanish, is available on our website. Ambassadors can download the toolkit, share it with members in their daily interactions, and share it with other stakeholders to extend our reach. We meet monthly with ambassador organizations statewide and continue to refine our efforts while we are in the first phase of our communications plan, which is the time before we know continuous coverage is ending. Next slide. This is an example of what's in the Ambassador Toolkit graphics. In our, it says, "Don't wait, respond, and update," which you can download those off the website. Next slide. Our next steps: we will continue to work with CMS to make sure our plans for unwinding continuous Medicaid coverage align with the federal requirements. We'll continue our recruitment and retention efforts to increase our workforce capacity. We will also continue to review our processes and procedures to ensure they are as efficient as possible. Finally, we will continue to work with stakeholders like you to build awareness of how they can support Medicaid members to complete their Medicaid renewals at the end of the COVID-19 public health emergency. And that's the end of my presentation. Thank you for your time.
All right, thank you, Gina. Thank you, Tricia. I see that we have our first question coming in the Q&A, which I'll read in just a second. But I want to encourage everybody who just listened to that big amount of information that was super informative to take a minute and type your questions into the Q&A. That'll help us sort them and ask them to our panelists. Okay, here we go. So we have one that's coming that said, would any of the outlined plans from HHSC affect children that were born from 2020 to 2022 during the pandemic, during the PHE, who meet regular financial Medicaid guidelines, not under COVID? In other words, would these children be eligible under continuous coverage or still be subject to the terms of the PHE period ending? I think if Gina's available for this, okay, there you are. I would love Gina to speak to this.
The impact would be the same for whichever Medicaid category an individual is in. So for children born in 2020 and 2022, they would go through a renewal process. If you're speaking to the children who are what we call deemed newborns, which are newborns who are born to mothers who receive Medicaid at the time of their pregnancy, they will receive an application to apply. Since they were not in, we don't do redeterminations for that, since they were deemed to be eligible based on their mother receiving Medicaid, but they will receive a notification and an application for them to apply so that we can determine if they continue to remain to be eligible, I should say.
Thank you. All right. I was going to say, I'll take the moderator's prerogative and ask a question, but never mind. Maura came in. Okay. And I think this is going to be Texas specific again, too. So this one will go to Gina to tell me about families who are right now working through the renewal process, because renewal packets have been going out for quite some time during the PHE, and they're submitting their paperwork now. Can you clarify whether they'll have to renew again when the PHE unwinds?
So if at the renewal, they were determined to be eligible, they will go through the normal renewal process, so that within the 12 months, they'll receive their normal packet, and they will go through the normal process as far as the administrative renewal process. So if they were, say, determined eligible as of October, their 12-month certification would be ending in September. They'll get a renewal packet in sometime, July or whatever the time frame is. So they'll go through the normal process in which they'll get renewals. For those who were determined ineligible, they maintain their coverage during the continuous, and we will have to do a full redetermination once the PHE or continuous coverage ends.
Thank you. And I will just build on that to say that I think that's one of the reasons that HHSC has emphasized, and we've all emphasized, and all the people in the webinar today have emphasized to their clients, it's so important to respond to requests from the agency now on renewal. Because if somebody renews now and is determined eligible and gets the 12-month certification period, that moves people out of kind of the big group of folks that'll have to have their eligibility determined at the PHE. That helps their clients, it helps the sisters, it helps the agency. I think it's a good question. I just want to build on it to emphasize that we should all be encouraging clients to renew now when they get those notices during the PHE. All right, okay, well, I got one more coming in, and then I'm going to turn to Tricia with one of my questions. Okay, which cohort? Gina, you spoke to this, but go ahead and repeat it for us, because I scribbled notes at the same time. You've got 3 cohorts, but when you've got a family that has a member in more than one cohort, will you talk one more time about how you will prioritize or bundle families across cohorts?
So the first cohort is that 1.4 million, and that's why it's the biggest cohort. So if you have family members who are in the second or third cohort, but you have one in the first, they're all going to be renewed in the first cohort. So they're all in those numbers.
Okay. All right. I think, Tricia, do you have a question to ask in this panel? I might have misunderstood, but I'm going to call on Tricia.
Me? No,
okay.
Not at this point.
Okay. Well, I'm going to call on you anyway, because I'll tell you, okay. as the moderator's prerogative here, I've got questions for both Tricia and Gina while people are trying to type. And let me tell you what, if you guys want to raise your hands too, I think we'll have a little bit of time to facilitate folks who can raise their hand. We can call on them. But first, Tricia, can you give us some examples of what you're seeing from states that of like innovative practices or best practices on updating addresses? Right. One of the things Gina mentioned, and we all know, is that HHSC is getting a lot of returned mail because so many people have moved during the pandemic. There's been so much disruption in housing, right? So what are some of the best practices you're seeing on helping clients update addresses in other states?
Yeah, so I can't start my video, just if someone can unlock it, but you guys can hear me. So Illinois has a great link to a one-page form, and the nice thing about that form is that it doesn't require the person to know what their Medicaid ID number is. It just says, what's your name, what's your old address, what's your new address, and then it's also gathering that important email and cell numbers, and actually asking for consent for those for cells to be used for text. So that's one really easy example. It's just a simple click. Also, we know that states are doing a lot of work with managed care organizations, and CMS has provided flexibility for the state to accept an updated address that a managed care organization has verified. So there's still a verification step, but that can ease the burden from states. And managed care companies are beginning to talk in their quarterly earnings calls with shareholders, about the potential impact of the loss of coverage of Medicaid enrollees. So this is on their radar screen, and they are very engaged in that. The state of Tennessee had very excellent results with a social media campaign encouraging enrollees to update their addresses. So I think, it's not one and done. There's no one perfect practice. I think the more steps that can be taken to encourage this, having providers, having either display materials or when someone checks in for an appointment. And I mean, I certainly can't get out of the doctor's office without confirming my address, even when I tell them that nothing has changed. Providers know almost immediately, if someone's address is being updated, and therefore they should be making those referrals to some of those simple ways for people to update those addresses.
Right.
And I will say, while I have the floor for a moment, Stacey, we do have a 50-state tracker, which I'll put in the chat in a moment, that is been perusing state websites to take a look at what kinds of information we can find that states have out there about the unwinding, about their plans for the unwinding, about the communication materials that they have. And so we would certainly encourage people who want to look at what's going on in other states. One of the things in the tracker is that you download it, and there'll be links in that download that take you directly to pages on other state websites or other examples of resources that have been provided. And I see Carla put it in the chat. Thank you, Carla.
She's good like that. All right, I think I'm going to go back. I think the next question that's come in, I'm going to direct to Gina. We all know that lots of folks who have Medicaid also are enrolled in SNAP. And can you speak to the ability that HHSC has, if you have it, to use some of the information you collect for SNAP redeterminations for also then use them again in Medicaid redeterminations?
Yes, since our system is integrated and we do the eligibility for all of the programs, that is what we strive to do, is to ensure that those redeterminations are done together so that we can use the same income. And sometimes that doesn't happen. Sometimes they apply for SNAP and come back and do Medicaid, and it's unaligned. But when we can, based on the policies and what we're allowed to do, we do try to do those together. And because it is integrated, we do use the verification as we can for each program, depending on, there are policies around the age of the verification and how old it is. So depending on that, if it falls within the confines of the policy, we will definitely use those. And of course, all of our electronic data sources we will use so that we don't have to then pend the member for additional information.
I appreciate that. And I think if it's okay with Tricia, I'm going to call on her for this one too, because I think there's additional tools that states can implement on to build on. Again, Texas, like Gina said, has this integrated app system, which really helps being able to use those verifications when applicable, when the policy allows it. But I think states have additional options they can take to use SNAP data. And if I'm putting you on the spot, Tricia, well, I'm putting Gina on the spot too. I'm putting everybody on the spot. Can you speak a little bit to the options states have on that front?
Yeah, and Gina may be a little more in tune with them on the SNAP side of things. The CMS is allowing states to submit what are called E14 waivers. It's a temporary waiver that allows coordination in a way that isn't allowed under the normal rules. And so in addition to using that, we've always been able to use the SNAP data for Medicaid determination, but you do still have to run eligibility. So there are additional flexibilities that when someone is enrolled in SNAP, there's also the flexibility of delaying and aligning that Medicaid renewal with the SNAP renewal. But I think that Gina may be more helpful in her response.
Thank
No, yeah, Tricia, you nailed it. But there are those waivers that the states can request for the unwind. And those are there even outside of the unwind, but with the unwind, they've made it a little bit more, I guess you could say, easier with that waiver. What it said is that irrespective of the differences in the policies between Medicaid and CHIP and SNAP, which there are, the household composition is totally different. On the Medicaid policy, you use more tax status based household composition, where on the SNAP side, it is those that are mandatory. So families and those who purchase and prepare together. So they might not even be family, but they purchase and prepare together. So those household compositions are totally different. SNAP, there are more income that we would use to determine eligibility versus on the Medicaid side, you would exempt that. So they did allow for states to apply for those waivers in order to simplify using the SNAP data to do that. And the state has been looking at all of the avenues in which the waivers and any allowances that the CMS is allowing. We're looking at everything that we can.
And I am going to put in the chat, there is a link, CMS has posted all the state E14 waivers. So if you want to take a look at some of what those flexibilities are and which states are picking them up, you can do so at that link.
And we are super grateful that HHSC is looking into those. I know they've already taken action on some regarding address updates, getting updated address data with some of the flexibility that's been allowed under those waivers, which is exciting. All right, I'm going to give everybody a warning on questions that I'm doing a new law. Oh, there's a question in the chat. Okay, I'm gonna do last call on questions. There's one in the chat. Well, I'll ask that. But I'm going to take this opportunity. There was a question yesterday that I still had a little bit of confusion afterwards, but with Gina here, she's going to clear it up. Can you, Gina, tell me? And you referenced this earlier. So when we read both the federal PHE guidance and the state policy on renewals together, can you clear if there's any discrepancy between getting a 30-day window to return your renewal packet and the information that's been requested as part of that packet, and what kind of timeline we have then for a separate request if your renewal is pending for missing information and you get a letter that, you know, you turned in your renewal packet, but not everything that was needed. If it's a 30-day timeline that applies to that missing information request, or a 10-day timeline.
It's 30 days. Our notice probably still has the 10 days. Sometimes because they are integrated and say they have a SNAP and a Medicaid, sometimes you'll see the 10 days. But I'm 99.99% sure it is 30 days that we must allow for providing any information. But you might see the 10-day on the notice, depending. Again, it's integrated.
Thank you. That might be where some of the confusion came from yesterday. All right, I think there's a question in the chat I'm going to look at. Okay, let's see if I got this right. Okay, can you confirm if it's still the best practice at renewal of Medicaid and CHIP to add a new program? For example, you can apply for pregnancy benefits or SNAP benefits or additional new benefits on that kind of starting screen of the renewal in YTB. Is it best to do a new application or add a new benefit during renewal? I hope I've summarized your question right, Mary Lou. And Gina's going to know that one.
It's best that at the time that you're renewing to request whatever benefits you need at that time, because your file date, is what really looks at when as far as the effective date of the coverage. So the sooner, if you're going to, renew, it's best that you do it all at the same time, especially because of your file date.
All right, you got it. Thank you for me and for Mary Lou on that one. Thank you. And I didn't have time to screen this one first, so I'm just going to read it. Gina can probably see it too. We've got a long question that's come in, and if no others come in, I'm just doing last call on questions. This might be it. When applying for benefits for grandkids, is there a difference between adopting, having custody, temporary custody, or CPS placement, and different qualifications for the approval? And forgive me, I'm going to go ahead and read this and make sure I can make sense of it. related to the PHE renewal, what would they have to do? And then if they're on SSI receiving Medicaid and they get a letter stating that they'll be coming off until they turn in their documents, will they still be on Medicaid until the renewal is approved? Thank you. I think there's a couple pieces there. Let me see if we can break it apart. The first one is when you're applying for grandkids who that you have custody for, temporary custody or CPS placement. Do you have any advice, or is there anything different that family's gonna have to do at the PHE renewal?
For I mean, it would seem if it's a renewal, it seems like the household composition has probably changed during that time. I'm just kind of, when they speak to a renewal versus, maybe an application. So, and I'm looking at the question here, trying to figure that out. But, in general, if you have your grandkids, again, for the Medicaid eligibility, it's based on tax status. So there's a lot that goes into what that means and who is counted and whose income is counted. As far as adopting, again, adopting is as if they're your children and they're going to be in the household composition. They'll count the income of the parent. Custody and temporary custody. Those we really don't look at. It's who has the child. Is that, as far as tax status, are you going to claim them as a tax dependent is mainly the question. If they're in CPS placement, depending on what the placement is, they do determine eligibility for Medicaid programs under placement with the state as a foster child. And there are some adoption assistance programs as well if you're adopting, but under the Department of Family and Protective Services.
Right, and I'm going to break the second one down into two questions, and I hope I get it right. Get the question right. So there's a separate process and eligibility rules around folks who are receiving Medicaid because they're on SSI. So have those folks had continuous coverage under the PHE as well? And can you speak to what they're going to see at the end of the PHE?
Yes. So yes, we are what we call a 1634 state. It's just from the Social Security Act. And individuals who are determined eligible by the Social Security Administration for supplemental security income automatically receive Medicaid. We get an interface file from the Social Security Administration and we automatically put them on Medicaid. Their eligibility is contingent upon their continuing to be eligible for SSI. So they have been receiving Medicaid because of the continuous coverage requirement. When the PHE and the continuous coverage ends, we'll be sending them a notice of their next steps to either apply for services under HHSC and the Medicaid programs that we have, or they need to get with the Social Security Administration about their next steps for receiving SSI. There might be some deviations depending on some groups where we'll send an application at a certain time versus sending a notice, but we will communicate with that population about their next steps.
Wonderful. And I think this is the last one. I'm going to pull apart part of that question and say, oh, thank you, Abia. There was a part of the question was about, are they still going to be on Medicaid until the renewal is approved? And let me have you back up, because Gina talked about during her presentation that there's how about I'll back up even further. Tricia talked about one of the best practices is for states to turn off kind of their auto close feature when they're working through this backlog. I think that's something that Texas has that's related to what Gina talked about, is that the cases will be worked and as renewals are coming in, and people will not be losing Medicaid while they're working through those renewals. So can you just confirm or restate what it's going to look like to enrollment assisters, what it's going to look like to clients when the PHE ends, for people to keep their coverage while you're processing those renewals?
Yes. So again, depending on the cohort is it's also dependent upon when we'll send their renewals. But for all of the cohorts, if we receive the renewal application or renewal packet timely, or if we requested information and they provide the information timely, if we have not gotten to it by the time we have in our timeliness standards, we will continue to provide Medicaid until we get to their renewal, so that there will not be a gap in coverage and they don't lose their eligibility until the state has the opportunity to do the full redetermination.
Thank you. I think it's important for all the enrollment sisters to know that they might be seeing that, because there's such a challenge, right, with in all of our organizations of hiring the staff we need in this labor market, and HHSC and the eligibility system is no different. And so if there's, because there's gonna be so many renewals all at once, if it takes a while to process through that workload, that clients will be able to keep who have turned in their renewal, right, will be able to keep their Medicaid while HHSC staff are working through that paperwork.
Yeah, and just, on that note, for just the workload in the workforce, I just want to, put a little kudos to the state. We've done some really good efforts at the retaining and recruitment. At the beginning of the year, we were about 20 or 21% vacancy rate. As of this week, we're at 9%. So we're doing, great work at really keeping those tenured staff, because that's, the tenured staff can work cases at a faster pace than the new workers, right? So really keeping that and building that more tenured staffing is important for our goal of keeping up with, the renewals and all the work that we have in the state.
Stacey, I wanted to go back to the first part of this question about children and grandparents.
Please.
So as I understand the rules, if a child is the tax dependent of someone who is not their parent or a spouse, then non-filer rules are what take precedent in determining that child's eligibility. And in that case, the non-filer rules, only the household is the child, the parents, their siblings, if the child is married or has children of their own. So in that case, the grandparents' income should not count toward the child's eligibility. So I just wanted to make that clarifying point, because it does make a difference as to whether that child's being claimed and whether they have that grandparent has legal guardianship.
You got into the weeds, Tricia. You are absolutely correct. Yes, I just wanted to keep it very high level, that it's really tax based, but you are absolutely correct.
Yeah,
it's hard to stay out of the weeds, Gina, in this work. So
it is. All right, and I've got another one that I'm going to direct to Gina. This is a question that's coming from a community partner. So when a family is receiving a notice for renewal in Medicaid, I assume it's Medicaid, doesn't say that. They log in as a community partner and they're looking at YTB. They aren't seeing a place where they can take action to renew, even though the family's getting a notice. And they believe that's because the PHE is in place. So just restate for everybody what actions clients should be taking now and community partners should be helping with now, and how they will see that renewal, if they will, and how they will see that renewal ability in the system.
Yeah, I'll have to go back to see why or what they are or not seeing. But as far as the communication being sent, it is not strictly FYI. We really want them to take anything that we send now and in the future to take action on those. As you stated, Stacey, that by doing that, we can see if they continue to be eligible, and then they will then be in the normal renewal cycles, and they won't have to then be under this continuous cohort and looking at them in the next 8 months. So they should, but I'm not sure why they're not seeing that, but I will get with our community partner programs and just kind of see what they're seeing and what the issue is. But thank you for that, Anonymous.
Agreed. Thank you, Anonymous. All right. And then we have a comment from Sue. Oh, I'm sorry, Tricia, did you want to build on that? Oh, but you're muted.
All right. I don't want to build on that, but I do want to ask Gina a question. But if you want to go with the next one, which shoot, I have the floor, so go
for
ahead.
it.
So Gina, I just wanted to ask a question. If providers can see the renewal date in the provider portal, if they're trying to confirm Medicaid eligibility, can they see the renewal date? And are those renewal dates, have they yet been, if so, have those dates already been updated for your plan, or when will they be updated?
And Tricia, do you mean providers such as like MCO providers, doctors, or who are we talking about?
The community health centers, physicians, offices, that sort of thing. I'm just trying to think of ways, because I know these are a lot of sisters in healthcare settings, making sure that people know that if someone is coming up to register for their, check in for their appointment, that they can check the renewal date then potentially and inform people when to be looking for their renewal.
Right. And I know we've worked with, and Rachel Patton is here to assist with that, because we've worked with our MCOs as well, so that they be our sisters, and to help with doing the renewals, and really, and we have an endeavor to try to get them to outreach as well if they haven't provided their renewals. From the community partner standpoint in the system, I would double check, but I'm sure that they can see the renewal dates. But as far as like the MCOs, I'm gonna defer to Rachel. I'm not sure what the MCOs can see and what they have access to. I'm pretty sure they are, but that's not my wheelhouse. So Rachel, can you answer that one?
Hi, yes, I can. Good morning, everyone. So yes, the MCOs do have access to the renewal date, and we will also provide supplemental files to the MCOs as we're unwinding the continuous coverage, so that they are able to assist their members with completion of their renewal paperwork.
Excellent.
Wonderful. I have another question. I'm going to direct it at Gina, but I'll tell you that this will probably be folks. She'll need to probably take this to folks too that are more in operations than in policy, although she might have a team member here. But Sue points out that HHSC wants, and we all want, people to respond to the renewal and the request for information as soon as possible. But there's a challenge because the envelopes that are provided are often too small to fit the renewal form in, or all the verifications in. And so then families have to figure out if there's a way to fax it, which is hard, or some folks are challenged to submit it online, and then you have to wait in line at the office. And so again, I'm acknowledging that this is probably not directly under Gina's purview, but can you tell me anything about the envelopes and forms and verifications fitting in them to be mailed back?
Right. Yeah. It really depends on how much verification a person needs to provide. Right. And the envelopes are, they're not normal envelopes. They're the bigger envelopes. We've done some changes to the envelopes. It has the red required action on it, so that the individual knows that it's something that they need to look at, and it's time sensitive. So we made those changes. We are looking to see if we can do an envelope that's in a color like yellow, but there's paper shortages and things like that. So that is something we're trying to work on, so that for at the end of the continuous that we'll be able to use those. But as far as that, because I see it's that most families can't afford the fax applications and can't submit online. We hope that they would be able to go to a community partner to assist them with that. And also, if they download the mobile app, they can upload that using their smartphones versus online in a computer. So it really, and they can also, request an extra envelope to be mailed if they need additional envelopes. But, it really depends upon how much verification they're having to provide. We use an average of what we think somebody's going to have to submit.
Thank you, Gina. And thank you to Sue, right, who's pointing out that for her clients, those new envelopes are too small. I think that's good. That's good and helpful feedback if it's a problem clients are finding in the field and the sisters are finding in the field. And I'm glad those folks are coming to you guys, so you can help them out. I think I'll wrap it up after this, but there's one more. Earlier, we had a comment on not being able to see the renewal in YTV. Right. And I think there's somebody followed back up to say the renewal is not always visible to them when they log into YTV. And so what they do is submit a new application. Okay. And again, Gina said she'd look into that. You're welcome to build on that more, but I think it's just a follow-up to give you more information about what they see.
Thank you.
Okay. Okay. Yeah. And there's more information at the bottom again. So good. This will help. Thank you to the anonymous attendee sending this in. This will help Gina make sure she can look into what you can see in the renewal portals. Let me make sure I'm reading this right and getting it right. But that's not a question. It's just more information on what you can see. Okay. I think that anybody else who's conference planning can jump in and tell me if they think differently. But I just want to say that I think we have learned a ton on the foundation, the policies of the PHE, the risks of unwinding the PHE, what the state's plans are. And then I think that all points to just how critical the help that community partners, that enrollment assisters, that navigators at CAC, that we'll be giving in this time that's going to be full of confusion, full of coverage transitions. That work we do is, that you guys do is going to be more important than ever. So I'm super grateful to Tricia and super grateful to Gina for coming in and sharing their information on the PHE. And I want to invite everybody to come back this afternoon. We're not done here, but there's more on the PHE on the best practices and tools and skill building and how enrollment assisters can help and what role we'll all play together. So please come back at 1:30. But right now, what I'm going to do, make sure I have this in front of me, is spin the wheel, right? We're gonna, oh, no, I got ahead of us. We got to do the evaluation. All right, so Danny or Carla will launch the poll. This is a quick 3-question poll, so you can give us information on the session today. Take just a minute and fill it out. And then we'll do the prize wheel drawing for the $50 Visa gift card. Okay, it looks like most folks have participated. I will let Carla and Danny close it out when they're ready. All right, I think the poll's closed. Is that right? So next we're gonna have Anne and the big raffle wheel.
All right, let's see that big raffle wheel. Which there we go. Believe it or not, this thing has all of your names in it. We're going to spin it. And when the names comes up, we're going to make sure that the name of that person is actually someone who is participating in this session. All right. So there's an email address. Somebody Villalpando, somebody whose first name starts with an N, and Carla's going to tell me who that is in just a minute.
This is Nancy.
Nancy Villalpando. That email address looks like a typo to me, but anyway, North Texas Association of Community Health Centers, maybe. Nancy, are you on? Are you on the call? You can go to the reactions tab and click on raise hand if you are, and we'll congratulate you.
I am not seeing a Nancy Villalpando in our attendee list right now.
Que triste. Okay, let's spin it again. Yeah, it's a tricky way to try to get you to do the survey, isn't it? Angela or Angela, depending on how you pronounce it. Are you here? Once again, if you go to the reactions and click on the raise your hand. Everybody was hungry for lunch. Okay, Angela.
Also not seeing an Angela.
All right, let's go again. for our new record, a third spin. All right. P. Hamilton.
Patricia Hamilton.
Tricia, are you here?
Oh, she's already raising her hand.
Yay! Congratulations, Patricia. We'll be emailing you your $50 Visa gift card. Thank you so much for being here. Just
All
under
right.
the.
All right, wonderful. Thank you. Congratulations. Join us again at 1:30. Gosh, I hope I get that time right. Yeah, 1:30 this afternoon. We're going to do PHE level 201 with some enrollment assisters on their tips and pointers and best practices. And I'll look forward to seeing you guys here, back here then.